كيف يا بروف الشمس واضحة، الصورة واضحة.
كيف؟
الحمد لله. كيف تمام؟
أروى كويس الحمد لله كويسين نحمد الله. زمن جاء
4 دقايق.
4 دقائق كويس. والدورة دي حرصنا إنه نعملها يعني ما دام قاعدين.
يجيك من عارفة.
فخلاص أنا قلت لمحمد جعفر أعمل أقدم خليها نعمل لها بيج ونخليها تنزل ولو كلام، يعني تنزل محاضرة صوت بلا صورة.
اوكي.
يعني برضه تكون أنا ما أعرف الصورة هو قال قريبة ولا شنو ما بعرف، ما خلينا بالنا. قال قريبة يعني من الكاميرا.
هو قال الصورة قريبة من الكاميرا، لكن يا بروف ممكن نعمل ترايل، يعني ننزل جزء بعد ذاك احنا نقيمه ولا شنو؟
أحسن ضروري. ولا أنت نزل 2 3 وأنا أشوف، يعني ما يحكم براه زي ما قلت صحيح.
خلاص تمام.
إن شاء الله. أنا هسه المحاضرات يمكن قريبة 30 هسه.
21 تقريبا. ماشي لل 30.
ما تم 30
بتحصل
21.
30. لكن بتحصل 30.
يعني لكن اب تو ناو 21. تحت الليل ان شاء الله اذا كان تم
بإذن الله
ان شاء الله. طيب who is there؟ ريم، يارا، هنا. دل 25 يا رو ولا 26 ولا كم؟
أنا قلت اسمهم ديل 25.
25 ايوه. لانه بعد كده 26 عندهم برضه اونلاين.
هم مفترض يحضروا معانا المحاضرات دي.
المفروض لان عندهم
26.
ايوه ناس ال 25 لسه على ناس الاوبس ود الشيخ والجماعه دي شغالين معاهم يا ربي. ولود الشيخ شغال مع 5 25 وعاطف
عاطف
24
دكتور عاطف
26.
26 دكتور عاطف مع 26.
ايوه والباطنيه معتصم معهم.
هو بيرسل لهم كلهم الكيسز حقته، بيرسل لهم كلهم.
المفروض يستفيدوا من المعروض يعني ما بس يختصر على ناسهم، مش كده؟
صح. لكن حسي حدوق لدينا اشوف لانه مفترض تخشوا.
اضرب لي دينا اقول لهم ناسكم المفروض يخشوا، لانه اللكشرز دي ثاني ما حتتعاد بسهوله.
صح.
امتحانات ماشيه كويس ناس 27.
اوكي.
اتذكر التعب اللي تعبنا في MD5 مع جيسيكا، قاعه في قاعه ما
والله
في
حسي منظم شغل.
ايوه تنظم.
والله.
وبعدين حتى حسن لحد امبارح 3 صباحا بيعمل في الفوتوكوبينج والتدبيس كلها توليناه نحن. نتولاه نحن ثاني ما فيها مشكله.
ما بتجع وجع، لكن مجهود كبير والله.
الحمد
حسن
لله.
وريان ومريم شدان. والله.
Okay, I think we can start, isn't it? It's time.
Yes.
Okay.
Yes, we can start.
Bismillah ar-Rahman ar-Rahim. Welcome to this yet another lecture on infectious and tropical diseases. And as we are approaching the 21st lecture, we are getting more and more into medicine, which is international, not only in tropics, but international medicine, but with touches on the tropical countries or the tropically environmental countries. Okay, in this lecture is about the HEPA meaning the liver. This is why we derive hepatitis, which is inflammation of the hepatocytes, hepatoma, which is tumor or cancer of the hepatocytes, and then hepatomegaly, meaning the megaly is large or enlarged. This is enlargement of the liver. This is an introduction to what we are going to touch today of hepatitis caused by viruses. And many viruses are capable of inducing liver damage or cellular damage, giving you hepatitis. From the start, we would like to say that the reaction of the body or the immunological fierce battle which is being put by the body, by the healthy body, is the major cause of pathology. Let us face it, that the body will try to rid itself from the virus, so it amounts quite a lot of resistance, and this is pathology. This makes the whole thing is pathological. So when we talk about viral hepatitis, although many viruses can cause hepatitis, like yellow fever, which is an arbovirus, EB, Epstein-Barr virus, can cause hepatitis. But the term viral hepatitis is restricted to hepatitis A, B, C, D, and E, or D is called Delta virus, but it is D and E, okay? And then we talk about the G virus, but these are the important ones of all. The talk cannot be visualized and understood unless we talk about the liver. The liver is a respectable, highly respectable organ constituting a large solid organ of 1.5 kilogram or nearly 3.3 pounds in a 70 kilo weight person. So it's a large organ, and this organ is a very complex organ. It's located in the right side under the dome of the diaphragm, on the right dome of the diaphragm. It overlies or superior to the stomach, and then covers the right kidney, and it is the gate. It is the gate of all intestine and receives blood from the splenic vein, and during utero, it receives blood from the placenta. So it is a communication. It's like a gate. Nothing goes in the systemic circulation before going into the liver. And so from that you can imagine the amount of work which goes in the liver. To me, the most important two events which happened in the last, say, 40 years or 50 years is one, the ultrasound, the invent of ultrasound in diagnosis of liver disease. Before that, we were very blinded about what happens in the liver. Even simple cysts we cannot see, even an abscess, liver abscess or amoebic liver abscess cannot be visualized, by any means at that time, apart from a chest X-ray to see the raised diaphragm. So it's so indirect. But with ultrasound, which was introduced late 70s and early 80s, this has really converted our understanding, the way we diagnose, and even the way we treat a liver disease. And as you know, we in Sudan, we have been in the forerunners to document the use of ultrasound in a liver disease of schistosomiasis. So that's number one, the invent of ultrasound. The second is the ability of hepatologists to transplant liver, not only the whole liver, which is used to be early on, but even a lobe of the liver, which can regenerate into a reasonable sized liver. So these are the two important, the ultrasound in diagnosis and the liver transplant in treatment. So it's amenable to diagnosis and treatment. Between these, I think the magnetic resonance has come and has complemented quite a lot of our diagnosis. It's a very sophisticated, it's difficult, need diagnosis, but very useful, and it complements our armamentarium in diagnosis of liver disease. Okay. As far as other investigative processes is concerned, is what we call the ERCP, which is endoscopic retrograde cholangiopancreatography. And this is obvious, it's use an endoscope. You get an endoscope in, you reach the duodenum, and then you inject a dye in the common bile duct on the right side and pancreatic duct on the left side, okay, and this is what's called ERCP, to visualize, one, the biliary system, two, to visualize the pancreatic system or pancreatic duct system. And this has been very useful in diagnosis and in treatment. However, with the introduction of magnetic resonance, now we have magnetic resonance, MRCP, which is magnetic resonance cholangiopancreatography. It is the same, cholangiopancreatography like ERCP, but here the MR is magnetic resonance. And now magnetic resonance has completely replaced ERCP as diagnostic, but ERCP still retains its ability, retains its function for treatment. You can cut the sphincter of Oddi and let a stone pass by, or you can have a stent, palliative stent, for relief of obstructive jaundice due to carcinoma of the pancreas, head of the pancreas, if you can't do anything about it. So ultrasound, then ERCP, therapeutic, and then MRCP, magnetic resonance cholangiopancreatography, and then the enzymes. Then the enzymes are biochemical markers or biochemical enzymes. Okay, the liver, as we said, is a complex organ, very sophisticated organ. It has two lobes, right and left lobe. The right lobe is palpable, as it not being soft, but it is palpable on the epigastrium. It's on the right side of the liver. Usually the liver is just at the tip of the costal margin, but we don't feel it because it's soft. Once it becomes hard, all right, or firm, like a cirrhosis of the liver or cancerous or whatever, even reticular endothelial abnormality, then the liver becomes harder and it becomes easy to feel. Okay, now it is very easy to determine the size of the liver. This is very important. In time gone by, we depend on clinical, we still do, by tidal percussion, which by now you all know, from the fifth intercostal space down to the tip of the costal margin. So the size of the liver is extremely important. If you have a shrunken liver, prognosis is different. If you have a large liver, then that is something else. If you have a normal liver, then you go for further investigations. So that is the way by ultrasound we can determine the liver size precisely. Okay, the liver could be viewed as a filter. It's a filter for all what we eat, what we breathe, what we inhale, okay? All of it goes to the liver to be purified, to be purified. And nothing will pass the liver unless it is cirrhotic. Nothing will pass the liver unless it's being treated properly to be excreted by the kidneys. So it's a filter. And in that filter, the liver will have enzymes, a lot of enzymes, microsomal enzymes. These are the enzymes which transform fat soluble to water soluble substances. And unless it's water soluble, it cannot be excreted by the kidney. So most of the chemicals, toxins, even drugs are lipid soluble, has to be converted into the liver by microsomal enzymes. So it's a factory for conversion of lipid soluble to water soluble using the enzymes which it has. Xenobiotic are chemicals. Xenobiotic is chemicals which we drink, flavoring material, coloring material, drinks and food. All these contain chemicals. Insecticide, we are exposed to insecticide in the vegetables and fruits. All these need to be treated before it's being pushed into the systemic circulation for excretion. So that is the filtering part. The filtering part is not a mechanical filter. It's an active filter of transforming some of these chemicals into a more acceptable form. So that is an active filter. The second thing is it's a manufacturing organ. The liver is a manufacturing and very important manufacturer of a lot of substances which are life dependent, or life depends on many of them. For instance, all circulating proteins are being synthesized and manufactured in the liver, apart from gamma globulin, which is manufactured or produced by lymphocytes. But the rest, albumin, coagulating factors, other immunoglobulin, all these are being transferrin, which is the carrier of iron. Then these are all manufactured by the liver. The albumin is the major protein in the plasma, which is constantly manufactured. Prothrombin, which is part of the coagulation system, is also produced by the liver with the help of vitamin K. Okay, so the two parameters of assessing the manufacturing ability of the liver is albumin and prothrombin. And if you draw a graph, the level of albumin and level of prothrombin in different states of the liver or different patients, you find a linear relationship, meaning that the factory ability of the liver will determine how much albumin and how much prothrombin. So this is what we call the metabolic function of the liver. Then the liver is a storage. Storage is not an inert storage organ. It's an active storage organ. For instance, vitamin B12 will be stored for 5 to 7 years. Even if you cut your intake of vitamin B12, you will have at least 5 to 7 years before you need more, because the liver can supply the vitamin B12 in the storage. Well, it's a storage for iron, and it's storage for glucose transformed into glycogen. And here, why we say it's an active storage, because if you need glucose, the liver can change the glycogen by glycogenesis into glucose. Vice versa, if there is too much of glucose, it can glycogenesis, okay, not glycogenolysis, meaning breakdown of glycogen. Glycogenesis, meaning that the glucose will be taken back into glycogen and it gets stored there. So it's a regulator of glucose in many ways. It's a regulator of glucose. Okay, as far as manufacturing is concerned, we have to remember that the liver manufactures cholesterol, and this is a very important substance used by the human, by the liver itself, to constitute bile, okay? It is used to constitute hormones, okay? The liver also produces a carrier of lipids, lipoproteins, and triglycerides. So this is very important, and it is reflected on the derangement of the liver if you have any cirrhosis or even hepatitis. Okay, the bilirubin again is, it's broken down. Hemoglobin, iron, and proteins is separated, is taken up by the liver and produce the manufacturing raw material for the hemoglobin from the liver. Transferrin, which is the carrier of the iron, is also produced by the liver. So it's a manufacturing organ, it's a filtering organ, it's a transformer of lipid into soluble components, and it also produce some reactive or immunoprotective proteins which help in the immunity. So one needs the liver, and the liver has a major characteristic of regeneration. Cirrhosis of the liver, which is cirrhosis of the liver is a state where hepatocytes are degenerating or being crushed, and other hepatocytes are being regenerating. So there is always a balance between an insult, a toxin, okay, like alcohol on the liver, causing death of the hepatocytes, and the liver will regenerate. It's a process which is indulged in the liver to keep itself alive. Okay, so this is why if you transplant part of the kidney from a donor, then you get full function if the liver regenerates, and this is a characteristic of the liver which is not seen in other organs easily. I have been intrigued by the regeneration of the liver in the 70s when I just finished the royal membership for specialization, and I wanted to start research I used to be in a gastroenterology unit of Professor Alan Reed in Bristol. I dealt with quite a number of liver disease patients. Even the first attempt of the first liver biopsy, which I did in Ward 29 in Bristol Royal Infirmary. Anyway, I was intrigued by the ability of the liver to regenerate, once it's small, shrunken, then especially if you stop the insult like alcohol, people who abstain from alcohol, then they have a regenerating liver, and it can increase in size, and the liver function test goes back to normal, what we call compensated state of cirrhosis. So this is something which I really discussed with the mentor, Professor Reed, and I said, we wanted to study why is the liver doing this and how it's going to do it, and what are the different effects of drugs, liver disease, whatever, on the size of the liver. And he asked me to go to the lab, the animal lab in the University of Bristol, to study on the liver of the mice. Anyway, I didn't like it. I didn't like the mice, holding the mice and dissecting it to get the liver out and seeing the different effects on toxins. I came back to him and said, well, I didn't like that, and I wanted to work on patients. And luckily, at that time, ultrasound was just coming up, and then I used to measure the liver size of patients, of normals in different situations, and I could see how the liver, being smaller in elderly people, how it enlarges in certain diseases, how it comes back to normal with a lot of factors. But so this is the intriguing part of that period. But now with a lot of facilities, one can do definitely far more better research. Okay, when we talk about liver function test, I think this is a misnomer, because these are not functions of the liver. These are indicators of disturbance of hepatocyte function. For instance, aspartate aminotransferase, which is AST. This is an enzyme which is being delivered when the cell is broken. It's just released, and it's an indication of acute liver cell damage. Okay, so serum albumin is okay, but then when you talk about alkaline phosphatase is produced by canalicular or sinusoidal membranes. Okay, this is why it's high in obstructive jaundice, alkaline phosphatase. But you remember we have two types of alkaline phosphatase. One is hepatic and one is bony alkaline phosphatase. How do you differentiate? By gamma GT or isoenzyme. So if the gamma GT is high, with a high alkaline phosphatase, this is liver. If it is not, then this is bone. And in bone, you can get it with Paget's disease, with osteomalacia, okay, with any regenerating bone. So if you get that alkaline phosphatase. Anyway, these are the tests which are being used. Prothrombin is more of a synthetic type of the liver, and it measures the manufacturing ability of the liver. So it's that is the importance. Obviously, bilirubin is an indicator. It's not a total indicator, because bilirubin can rise up in cases of hemolysis, cases of obstructive jaundice, cases of hepatic damage, cases of acute fulminant hepatitis, whatever. So bilirubin is there, but it needs, to put all these together and see if you can come out with an answer for the liver disease. I would like also to indicate that now we have better tests. We have immunoglobulins, we have IgM, IgG, which are attached to, which indicative of certain viruses, which can give an indication of liver disease. So this is the important part of that important organ, which is the liver. Okay, being there at a gate, it receives quite a lot of substances. No substance, be it nutritional or xenobiotic or drugs, a filter which is defective, like in cirrhosis of the liver. And if you have severe cirrhosis, like in hepatic encephalopathy, nitrogenous products will go in, okay, ammonia will go in, because the liver normally will take the nitrogenous products and convert them into amino acids, okay? But if the liver is filtery or cirrhotic, then a lot of substance can bypass the liver and causes encephalopathy. So that is something which you ought to remember when you have a patient with jaundice, to say that this is a step further than just the chronic cirrhosis. This is going into the acute phase of liver damage, what we call liver failure. Okay, so so you have to be aware of the fact that the viruses can damage the hepatocyte in many ways. Okay, the iron or copper, if deposited heavily in the liver, can cause damage. Okay, I'm just giving you examples of how the liver cell can be damaged. Okay, if you have iron, you will have hemosiderosis. If you have copper, you will have Wilson's disease. And then if you have other deposition like hemoglobin, is being abnormal, or things like iron therapy, if it is overloaded, especially in patients with thalassemia, you can deposit a lot of these chemicals in the liver and causes damage. So the liver works hard, no doubt about this, but it has to be looked after very carefully in many ways. Okay, so avoid alcohol, avoid toxins, and toxins could not only be in the environment, but we take toxins in form of drugs. One of the very good causes of hepatic cell damage is paracetamol in overdose. And now in the Western world, when fulminant hepatic failure is not common with viruses, the paracetamol overdose is for suicidal or for depression or whatever. This is a cause of acute hepatic necrosis. Okay, so now back to the viruses. We have about half an hour to finish some of the viruses which cause liver damage. Okay, as we already alluded to, that viruses generally can cause hepatitis. Okay, but there are varying level of severity. Okay, and those viruses which deserve the word viral, these are the A, B, C, D, E, and G. Okay, and these viruses have a very interesting history. Okay, the A virus is a virus which is it's an RNA virus. Okay, it's a fecal-oral transmission, meaning that it's been taken from the feces, and from the feces meaning not maybe direct from the feces, but contamination of the feces, be it water or food or flies. So the A virus is an oral, a fecal-oral transmission, and so is the E virus. So let us take them together. Fecal-oral, and they cause acute hepatitis. However, both of them are of benign nature. They have a benign nature. Okay, for hepatitis A, you may need 2 weeks, okay, as an incubation period, and then you have a prodromal symptoms. You feel weak, anorexic, loss of appetite, vomiting, fever. Okay, and these are symptoms which can mimic malaria, typhoid, influenza, and whatever. Okay, in these prodromal symptoms, unfortunately, the patient can excrete a lot of viruses even without being diagnosed as hepatitis A. So it goes on, but it goes a normal route. It goes in a normal route, okay, to end up by clearance. And by clearance, the patient gets immunity. We call immunity, usually long-lasting immunity. The disease does not show in children, Children can be affected naturally, but if they are below 3 years of age, they cannot get a very florid hepatitis. They can get subclinical or asymptomatic hepatitis. This is what we call non-ecteric. It's hepatitis non-ecteric, meaning that there is inflammation of the liver, but the picture of hepatitis is not there. So it's mainly a disease of adults, okay, and usually goes as an outbreak. It goes as an outbreak. So if you have somebody who is feeling, is weak or feverish, with a lot of abdominal pain, nausea, and vomiting, sometimes diarrhea, general feeling ill. But once the jaundice appears, the penny falls. That is when you think about hepatitis. And if you draw a curve, then gradually it goes down. It goes down. Okay, naturally it goes down. And this is the confusion comes when cauterization, cautery on the side here, the cautery of patients who have hepatitis. And once they are cauterized, patients will be better. It's not because of the cautery, it is because of the natural history of the jaundice and hepatitis A. Okay, so once you finish it, then you get immunity. And luckily, there is a vaccine. There is a vaccine which now is being offered to children at various ages. It's available. Then the patient or the individuals will be immunized against hepatitis E. Okay, so in children, in 80% of patients, is silent. Okay, and in adults or young people, in 80% it is overt. Okay, and there is no chronic sequelae to the hepatitis A. This is important because when we come to talk about hepatitis B and C, this is a major problem which we deal with, is chronicity of these viruses to the end of not only having chronic active hepatitis and cirrhosis, but to a level of hepatocellular carcinoma. Okay, and the diagnosis is, it can be easy, okay, by the history, the liver. And if you examine the liver, you can find it enlarged and tender. In 10% of patients, we can find the spleen enlargement. And in rare cases, we can even find skin rash and lymphadenopathy. Okay, if we find an IgM, anti-hepatitis A, then this is an active disease. If you find an IgG, hepatitis A, then this is an old disease, and now you have immunity. This is for all these viral hepatitis IgM is an indication of active infection. IgG is a long last, it's a recovery period. Okay, and then we talk about hepatitis B. Hepatitis B has a good history or an interesting history as well. You know, in the 70s, an antigen was found in the plasma of some hemophiliac aborigines. Aborigines are the population of Australia before the white people came and exterminated them. They had a genocide there. Okay, before then, a hemophiliac aborigine was found to have an antigen in the blood. Okay, and this is very intriguing. They could not say what this antigen is. Okay, and they called it Australian antigen. Australian antigen. But then it's very quickly linked to hepatitis, which is a severe form of hepatitis. And the Australians protested, and it was called then hepatitis associated antigen, because up to that time the virus was not discovered. Okay, so from there we knew that this is the antigen, and this is the envelope of the virus, which is made by the effect of the virus on itself and by the hepatocyte. And this antigen usually is set free in the plasma. This is why we see it in the plasma. And hepatitis S or surface antigen is a marker of chronicity. If you have it 6 months after an infection, then you are chronic carrier of hepatitis B. So S is a carrier indicator for after 6 months of infection, because in the first 6 months of infection, you can clear the virus. Okay, if you don't, by 6 months, you will have an indicator which is surface antigen. HB, small s here, antigen. Okay, surface antigen. And the surface antigen is the basis for vaccination, because luckily this virus has a very efficient vaccine, developed in recombinant yeast with the DNA of the virus inbred in the yeast, and this forms the vaccine which is being offered. And I'm very pleased that all our students in UMST are being vaccinated from the word go when they are admitted to the university. And the vaccine should be given at 0 time, 1 month's time, and 6 months' time. But you can do it every month, 0, 1, 2, and then you have a booster dose once you go into the clinical period. Okay, so what are the other components of the virus? The other components of the virus is the core, which is the virion, and it is the virion of the replication of the virus, the virion. Okay, it's a core, and this core has nucleocapsid, which is DNA, circular, incomplete circular, double-stranded DNA within the DANE particle. So the DANE particle is the core antigen, and it is the virion. So the rest is the sheath, which is the surface antigen, and there is a cleavage, nuclear cleavage of an antigen which is called E antigen. Okay, this is the cleavage. I'm saying this because these have different meanings from the epidemiology of viruses or virus B. That it has different meanings. Okay, if you find S, then are either a carrier or if you find an S antigen. If you find S antibody, you are an immune. Okay, if you have an attack, okay, and the attack continued for 6 months, and then after that there is no surface antigen, you clear the virus, and then you develop antibodies to the S. So you have hepatitis S antigen. Okay, and the major cause of damage to the body or to the cells is the human being himself or herself. It is the host immune response, which is the severer host immune response, the more pathology you will get. Okay, so it's the core antigen, which we have core antigen and core antibody. We have the S antigen, which is the envelope, which can be found free in the plasma. We have the E antigen, which is the cleavage from the envelope. And the E antigen is, if it is there in the blood, it usually indicates active replication of the virus. So it's not good news. Okay. Okay, what happens if you contract hepatitis B? You will have different scenarios. The first scenario is you could have an acute hepatitis. And this acute hepatitis is similar to that of A, okay, with prodromal symptoms, with nausea, vomiting, fever, and then jaundice appears, okay? The jaundice appears. The incubation period is usually between 6 weeks to 6 months. 6 weeks to 6 months, okay? And you have a pre-icteric. Icterus is yellowness or jaundice. Icterus. Icteric patient meaning a patient with jaundice, okay? So the prodromal phase is you will have arthralgia, you can have an urticarial rash, okay? And then the picture of jaundice appears. Okay, because of the immune complex of the hepatitis B with the body, you can have arthralgia, which is of immunological nature. You can have arthritis, which is also of immunological nature. Okay. What happens if you have an acute attack? Okay. In children, okay, in children, especially neonate, in 90% of those who attract hepatitis B during neonatology, 90% will have a long-last sequelae of a carrier of chronic active hepatitis or chronic persistent hepatitis, and later on in life, they may have hepatocellular carcinoma. If an adult contracts hepatitis B, then the chances are very high to clear it. So it is important to remember that the chronicity is very much dependent on when the patient attracts hepatitis B. Okay, if you have a group of carriers, 1% of them will go into, 1 to 5% of them will go into chronicity, chronic liver disease. They become, and then 1% of them can develop hepatocellular carcinoma. 8% of them can develop proper cirrhosis. And it has been noted, if you have a transplant of the liver, the virus can reappear in the transplanted portion of the liver or the liver. Okay, who gets the hepatitis B? Obviously, it's a blood-related virus. So if you have a needle injected blood transfusion, serum transfusion, like factor 8 in hemophiliacs, which is the story of the first antigen found. Then it is blood related. So even if you go to a barber and you get your head, you know, cut, then if he uses a razor and then he cuts you down, the razor is not clean, then you can have hepatitis. Okay, the virus is recovered from the mosquito. It was recovered from the mosquito, but up to now there is no evidence that the mosquito can transmit the virus. So the indications of where people get the virus is nowadays is not the blood, because blood in many parts of the world is being very well screened. It is heterosexual or even homosexual. Homosexuals are more likely to develop hepatitis B, but even heterosexual. And in the big world, the contraction of hepatitis B is through sexual intercourse. It could also be contracted by vertical perinatal period, that is during delivery, parturition, and nursing and blood and lactating. So you have a very proximity of the child to the mother, and this can give hepatitis B. So it's a vertical transmission, right? And it's a horizontal transmission from man to man or from mother to child here at the neonatal. And as we already have said, that this particular period is critical, because if a child contracts hepatitis B, then the sequel in the future is not very bright. Okay, 80% of them may have chronic sequelae. Okay, as far as diagnosis is concerned, we can have very obviously the tests which indicates the damage of the cells. Okay, but we can have specifics of the virus, as we said, the surface antigen. Okay, and if the E antigen is there, meaning that this is a replication phase of the virus. Okay, then we have the core antigen. Okay, and then we have the core antibody. We have the core antibody. Okay, so these are the tests which we can do. But the very specific tests for replication and for diagnosis beyond doubt is hepatitis B virus DNA. This can be measured, and if you found that this is no doubt, this is related to hepatitis B virus. Okay, and through the activity of the virus, we can draw quite a lot of conclusions and measurement of chronicity. There are two types of chronicity, which is a chronic active hepatitis. Years by, it used to be called lipoid hepatitis from lupus erythematosus. And lupus is the classical disease which we know of autoimmune disease. So the people who are trying to say this is chronic hepatitis due to an autoimmune process. Chronic persistent is just a cirrhosis which is lingering on without activity. So it's chronic active and chronic persistent hepatitis. The hepatoma, hepatocellular carcinoma, hepatitis B, and also C when we come to it, predispose patients to hepatocellular carcinoma. It's been seen that the genome of the virus link to the DNA of the hepatocyte, to the genome of the hepatocyte, thus changing certain characteristics and allowing the cell to proliferate and go mad and insane. So with hepatocellular carcinoma, unfortunately, hepatocellular carcinoma, if it develops, it's a very lethal disease. It has no specific treatment. Bibramycin and others have been tested, but they have no effect. So it's if somebody catches hepatocellular carcinoma, then it is almost exclusively fatal. And this is why we say if you protect yourself against hepatitis B by vaccine, then this is a good price to pay for protecting yourself against a nasty hepatocellular carcinoma. One aspect of hepatitis is fulminant hepatitis. All right, fulminant hepatitis. What is fulminant hepatitis? Fulminant hepatitis is severe hepatitis. Okay, severe hepatitis with massive destruction of hepatocyte over a short period. Okay, it can occur, by the way, with hepatitis A, but not very usual. And we said it's a benign condition as far as chronicity is considered. But if you have a patient with HIV or a patient with severe malnutrition, especially child, then fulminant hepatitis can occur rarely with hepatitis A. However, with hepatitis B, you can have fulminant hepatitis. And fulminant hepatitis essentially is encephalopathy. You have an encephalopathy with a shrunken liver being attacked by the virus and usually ending up with very lethal or fatal outcome. So it's a disease which is we have to look for, and it can occur with malnourished children, with pregnant ladies. One of the causes of maternal mortality is fulminant hepatitis, because as you know, pregnancy is an immunosuppressive state. So the lady can be succumb to hepatitis B if it can be severe, and fulminant hepatitis can occur. It's amazing that the liver in a very few days from that size will shrink by death of cells, and the encephalopathy can occur. So hepatic failure is usually associated with encephalopathy, and the flapping tremor, which can occur with hepatic encephalopathy, can occur with other things, but it is not pathognomonic. It can occur as a sign of hepatic failure. So beware of the fulminant hepatic encephalopathy, fulminant hepatic failure, and there all the tests will be abnormal: jaundice, encephalopathy, small liver, bleeding because of the coagulation, and end-stage renal organ damage, which can end with death. So hepatitis E, you remember we mentioned it with A. The epidemiology is the same, but also it can occur in neonates, in children, and pregnant ladies. And it is usually mild. The E is mild, very similar with the cousin of A, but it occurs mainly in children, all right, especially malnourished children and pregnant ladies. And it comes as an outbreak. We used to have an outbreak in Darfur for some time. Now, recently, there is an outbreak of an E hepatitis in South Sudan. Okay, so that is A and E together with fecal-oral, and the B is hematogenous, spread or sexual, both homosexual and heterosexual. Okay, it is not up to now proven that hepatitis B can be transmitted by mosquito. Just like AIDS, we did not prove that mosquito can transmit AIDS. Okay, as far as clearance on hepatitis, there are a lot of antiretroviral drugs which can be used to clear the state of chronicity, but it is not for C. It has been proven in Egypt that you can clear some of the chronicity, but these are drugs which can be talked about in another session, which involves quite a lot of side effects and talent to use these drugs to completion and to recovery. So I think with that is the hour which I have is about viral hepatitis. We touched on the liver, which is an important organ, and we touched on some of the investigations of the liver in the state of disease, and luckily, at least we have two vaccines. Vaccine A for A, which can be given from birth or soon after, and then we have vaccine B, which is now included in the pattern of vaccines given to neonate. So with that, I think we can solve a lot of problems with these vaccines. Okay, obviously they need to have a complete dosage of the vaccine, and necessary to have the booster dose. I'm saying this because some of our students, especially dental students who deal with a lot of blood in the gums and the patients, okay, they use double gloves, but they have to have a booster of hepatitis B, as well as taking care of themselves during practice with patients with HIV/AIDS. But the chance is, even with a prick, okay, over a glove, the chances of getting HIV is remote. And the HIV virus is very sensitive. The hepatitis B virus is very resistant. So if you throw hepatitis B in the air and dry, it can live there for a few days without being dead, it can be contracted. So if you have a dried blood in some area and you expose yourself to it, you can still have hepatitis B. But if that blood is coming from AIDS or HIV/AIDS patient, then the virus would have been dead by the time when the blood is dry. With that, I would like to thank you very much indeed for being with me. And now we are working on putting these lectures into a YouTube so that all students all over the Sudan and others can get access to them, and hopefully it will be useful for at least some of you. Thank you very much indeed. Keep well.